Chapter 16, Trauma, Stressor-Related, and Dissociative Disorders. Traumatic life events are associated with a wide range of psychiatric and other medical disorders. And understanding how the long-term effects of that trauma could impact effective treatments available, and finding people in need of treatments do not always get the care that they need. These trauma-related disorders can take different forms, from attachment disorders, such as reactive attachment disorder or disinhibited social engagement disorder, to post-traumatic stress disorder, PTSD. And PTSD, I know a lot of people think of it as just veterans, but it can affect anybody with a traumatic event, from children to the elderly. Reactive attachment disorder would show a consistent pattern of inhibited, emotionally withdrawn behavior, unresponsive to caregiver efforts to offer comfort in their distress. Disinhibited social engagement disorder, on the other hand, is no normal fear of strangers, seemingly unfazed by separation from the primary caregiver. And risk factors include neurobiology and environment, which is going to be the case for a lot of these psychiatric disorders, getting back to that nature versus nurture. Post-traumatic stress disorder is seen even in preschool children, with manifestations such as a reduction in play or play reflecting aspects of the trauma, self-blame, detachment, estrangement, loss of interest in significant activities, and mood changes, sleep disturbances, hypervigilance, and loss of concentration. Prevalence rates for PTSD in children has not been reported. However, research on adolescents indicates that adolescent rates are at 5%. According to the U.S. Department of Veteran Affairs, approximately 15 to 43% of children and teens experience trauma. Of those, more girls than boys go on to develop PTSD, with 3 to 15 and 1 to 6% respectively. Nearly 100% of children who witness their parents' murder or sexual assault will develop PTSD. Other alarming statistical relationships with PTSD are for children who are abused, exposed to a shooting at school, and who see community violence in urban settings. How one reacts to trauma has a major grounding in genetics and neurobiology, including how that trauma dysregulates the neural pathways that integrate emotional regulation and arousal, the triggers of hypoaroused state leading to dissociation, and that polyvagal theory we discussed a few weeks ago. In polyvagal theory suggests that the autonomic nervous system is not limited to a fight or flight response or threat. Instead, there are actually 3 different responses. The myelinated ventral vagal responses, these are activated during social or intellectual engagement, when the individual is in a state of pleasant, not overwhelming arousal. Next would be the unmyelinated ventral vagus response, and this is activated when we perceive a threat. The attending sympathetic arousal symptoms of a rapid heart rate and rapid respirations, that fight or flight. And the third response is the dorsal vagal response. That occurs to dampen down the sympathetic nervous system. This is a parasympathetic response. Remember, your sympathetic and parasympathetic are in a constant tug of war, with the sympathetic pulling the heart rate and respiratory rate up, while the parasympathetics pulling it down. A good example of this would be playing dead when extremely threatened. In humans, the person may just want to sleep or escape through mind-numbing activities and stay in this hypo-aroused or depressed state, rather than dealing with their hyper-aroused or anxious state. There will be many factors in how a younger child deals with stress, especially external factors such as those family supports that either add support or add stress to their lives. And also resilience. Some children are going to be much more resilient than others. The term resilience refers to positive adaptation or ability to maintain or regain mental health despite issues, troubles, and traumas. In our first case study, Max, age 6, has been traumatized by a history of violence from an alcoholic father. A neighbor calls the police one night, and the father is taken in for questioning and agrees to enroll in rehab. Max is taken to the hospital for assessment of his arm, which is covered with bruises. His mother is distraught and says she wants to help for the whole family, including her husband. The nurse prepares to assess Max's mental health. In addition to the essential assessment data we would normally collect, we would also be assessing developmental status. We can do this with specialized tools such as the Denver Tube developmental screening test for infants and children up to 6 years of age. In this tool, abnormal findings in the development and mental status assessments may be temporary. The nurse working with the parents may handle stress-related behaviors or minor regressions. However, as young people use maladaptive behaviors over time, they become more vulnerable to developing other psychiatric disorders. Early intervention is essential to reduce further disability. The nurse prepares to assess Max's mental health, identify some broad areas of mental health assessment for this child. And these broad categories to assess include safety, general appearance, socialization, activity level, speech, coordination and motor function, patient's affect, manner of relating, intellectual functioning, and their thought processes and content. Other essential data for PTSD specifically would be things like nightmares and night terrors, intrusive traumatic thoughts and memories, or re-experiencing flashbacks. Interventions for children with PTSD include using interactive processes, establishing trust and safety, using developmentally appropriate language, teaching relaxation techniques before trauma exploration, and using art and play to promote expressions of feelings. Moving through the stages of treating younger children going through traumatic experiences, stage 1 would be provide safety and stabilization. Stage 2, reduce arousal and regulate emotion through symptom reduction and memory work. And Stage 3, catch up on developmental and social skills, develop a value system. Involve their caretakers or parents in the one-to-ones, unless they are involved in the cause of the trauma. Educate the child and caretakers about the grief process and responses to the trauma. Assist caretakers in resolving their own emotional distress about the trauma, and coordinate with social work for protections. Treatment is effective when safety is ensured, anxiety is reduced, and stress is handled adaptively. Emotions and behavior are appropriate for this situation. Child achieves normal developmental milestones, and the child is able to seek out adults for nurturance and help when needed. Biologic treatments and medications will be used in conjunction with psychological therapies, such as cognitive behavioral therapy. Just like with other conditions, it's not just one specific intervention. It's usually going to be a multitude of interventions working together. Question 1. Which of the following should be established first in working with a child with PTSD? Would that be A, provide safety and stabilization, B, reduce symptoms, C, develop a value system, or D, provide support for catching up on developmental and social skills? And that answer here is going to be A, provide safety and stabilization. Just like with our Maslow scale, we always got to have that safety physiologic needs first. Continuing with our case study, before going home from the hospital, Max and his family began intervention therapy, which is probably the least useful strategy at this time. Would that be A, establish trust and safety in the therapeutic relationship? B, use art to help Max express his feelings? C, bring Max's father into one-on-one play therapy sessions? Or D, teach Max and his parents about grief? And that answer here is going to be C, because Max's dad has been the cause of his trauma. It is not yet appropriate to bring Max's father in for therapy at this time. Trauma-related disorders in adults could be everything from post-traumatic stress disorder to acute stress disorder or even adjustment disorder. Examples of PTSD-inducing events include military combat or hostage situations, crime-related events, natural disasters, or human disasters and accidents. About 60% of men and 50% of women have at least one trauma in their lifetime, and how they react to these can vary wildly from patient to patient. Some people are much more resilient. They also have more other comorbidities going on, and there's a lot of different factors that can affect how they deal and cope with each incident. Some common symptoms within post-traumatic stress disorder include flashbacks, which are re-experiencing the trauma, avoidance of stimuli associated with the trauma, and persistent symptoms of increased arousal, hypervigilance, and alterations in mood. For assessment, there are primary care PTSD screening tools, PTSD checklists, and a more thorough comprehensive assessment is indicated for those who initially screen positive. When diagnosing anxiety, always try to determine the level, moderate, severe, or panic. A general outcome for a post-traumatic response is simply an improved response to the trauma. The stage model of treatment for trauma includes Stage 1, providing safety and stabilization through creating a safe, predictable environment. Stage 2, reducing arousal and regulating emotion through symptom reduction and memory work. Stage 3, developmental skills catch up by enhancing problem-solving skills, nurturing self-awareness, and social skills training. When evaluating the patient, Recognize symptoms as related to the trauma. Use learned strategies to manage their anxiety. Make sure they have no flashbacks or intrusive thoughts. Sleep adequately without nightmares. Assume usual rules. And have satisfying interpersonal relationships. Our primary medication classes are going to be antidepressants and SSRIs. A patient is being evaluated in terms of successful outcomes. Identify things the nurse would look for as evidence of success in each of these three areas. Manage anxiety, experience enhanced self-esteem, or exhibit an enhanced ability to cope. Miss S, age 19, works night shift at a gas station convenience store. She is brought by police to the ED, who explained that tonight she was working behind the cash register when the store was robbed. A man rushed in wearing a ski mask, she says. He waved a gun and 2 customers dropped to the floor. A 3rd customer was able to crawl out the back through the storeroom. I wouldn't take my eyes off that door. The gunman ordered Miss S to open the cash drawer. I couldn't move, she says. I just kept staring at that black door, thinking about the guy that escaped. I thought about how he was like maybe 30 feet away on the other side of the door, and he could smell the outside air in the gas pumps. And here I was, so close but trapped. It's like I could smell the gas outside, but I couldn't hear this man yelling into my face. Acute stress disorder develops after exposure to a highly traumatic event and is usually diagnosed 3 days to 1 month after the event. To make a diagnosis, 8 or more of the following during or after the traumatic event must be present. A subjective sense of numbing, derealization, inability to remember at least one important aspect of the event, intrusive distressing memories of the event, recurrent distressing dreams, feeling as if the event is recurring, and intense prolonged distress or psychophysiologic reactivity. Other things that may be present are avoidance of thoughts or feelings about the event, sleep disturbances, hypervigilance, irritable, angry, or aggressive behavior, exaggerated startle response, and agitation or restlessness. Which symptom is Mrs. S displaying when she talks about the way she thought about the man who escaped? That be A, exaggerated startle response, B, hypervigilance, C, derealization, or D, agitation. And our answer here is C, derealization. This is a sense of unreality related to the environment. This can occur either during or after the traumatic event. As the gunman was shouting orders into her face, her thoughts took her outside to the man who was safe now. The effect was so strong that she reports being able to smell the gas tanks. Derealization is a form of protective mechanism in the face of a traumatic event. Mrs. S reports that she feels numb. She is shaking almost uncontrollably and startles easily as well. She is diagnosed with acute stress disorder. Predict the most likely nursing diagnoses and outcomes the nurse will identify for Mrs. S. There would be a lot of different nursing diagnoses that could be in play here. Post-trauma response, impaired adaptation, anxiety, and we should be identifying outcomes such as reduced response to that trauma, improved adaptation, and decreasing her anxiety. For interventions, establish a therapeutic relationship with the patient and assist them to problem solve. Connect them with support personnel or support groups. Educate them about the condition and collaborate for a coordination of care. Ensure and maintain the patient's safety and monitor their responses and/or adherence to treatment. Again, your primary psychological therapy is going to be that cognitive behavioral therapy. And it's been found to be effective in reducing the subsequent development of PTSD for people with that acute stress disorder. On the other hand, adjustment disorder is a milder, less specific version of acute stress disorder or PTSD. It's precipitated by a stressful event, and the symptoms may include all forms of distress, such as guilt, depression, anxiety, and anger. These feelings may be combined with other manifestations of distress, including physical complaints, social withdrawal, impaired occupational function, and academic decline. As with stress disorders, dissociative disorders also occur after a significant adverse experience or trauma. The predominant response is a severe interruption of consciousness. Dissociation is an unconscious defense mechanism that protects the individual against overwhelming anxiety through an emotional separation. However, this separation results in disturbances in memory, consciousness, self-identity, and perception. Mild, fleeting dissociative experiences are common for all of us, autopilot. However, pathological dissociation is distinctly different from autopilot. Symptoms of dissociation may be either positive or negative. The positive symptoms refer to unwanted additions to mental activities such as flashbacks, while negative symptoms refer to deficits such as memory problems or the ability to sense or control different parts of the body. With the clinical picture, these occur after significant adverse experiences or traumas. Individuals respond to stress with severe interruption of consciousness, while that unconscious defense mechanism, it helps to protect against overwhelming anxiety through emotional separation, and results in disturbances in memory, consciousness, self-identity, and even perception. These dissociative disorders can take many different forms, and there are certain culture-bound disorders that exist where there is a high level of activity, a trance-like state, and running or fleeing, followed by exhaustion, sleep, and amnesia regarding the episode. These syndromes are called piblocto, seen in native people of the Arctic, frenzy witchcraft among the Navajo, and amok among Western Pacific natives. These syndromes, if observed in individuals native to the corresponding area, should be differentiated from other dissociative disorders. Dissociative amnesia is another condition to be aware of, and deals with an inability to recall important personal information, often of traumatic or stressful nature. This could also be called a dissociative fugue, which is a subtype characterized by a sudden, unexpected travel and inability to recall one's identity and information about the past. Dissociative identity disorder must be This is not to be confused with depersonalization or derealization disorder. And this involves persistent or recurrent episodes of depersonalization or a focus on self, extremely uncomfortable feelings of being an observer in one's own body or mental processes. On the other hand, derealization focuses on the outside world, meaning recurring feelings that one's surroundings are unreal or distant. The person feels as if walking around in a fog, bubble, or dream. We're going to complete this with a memory assessment, a history, especially of patient's self-harm, mood, impact on the patient and family, suicide risk, and self-assessment. There could also be many nursing diagnoses associated with the condition, such as disturbed personality identity, impaired role performance, or specific levels of anxiety. And when planning for the care of these patients, again, phase 1 is safety, stabilization, symptom reduction, safety, safety, safety. Phase 2 is confronting and integrating traumatic memories. And phase 3 is the identify, integration, and rehabilitation. The implementation of these interventions to treat this condition would be a process of integration and linking previously disconnected neural networks. Other interventions offering emotional presence and teaching could also be very effective. We should also focus on teaching the patient grounding techniques, and these deal with bringing the person's awareness to noticing real things in the present to help counter dissociative episodes. An example of a grounding technique can include stomping one's feet on the ground, taking a shower, holding an ice cube, exercise, deep breathing, or counting beads. Reevaluating the effectiveness of treatment for dissociative identity disorder is integration and helping to bring these identities together. Overall treatment is coordinating functioning among those alternate identities to promote that optimal functioning. Again, we're focusing on patient safety, reducing anxiety, integration of the fragmented memories, and new coping strategies. There are no specific medications for the condition, though medications treating hyperarousal and intrusive symptoms may be effective. They would also be used in combination, such as cognitive behavioral therapy again, psychodynamic psychotherapy, exposure therapy, hypnotherapy, neurofeedback. This is going to be a very difficult condition to treat. And finally, wrapping up, a nurse assesses a patient diagnosed with dissociative identity disorder. Which finding would likely be a part of the patient's history? A, travel to a foreign country, B, physical and sexual abuse, C, thyroid dysfunction, or D, eating disorder. And again, that answer is going to be B. It's usually going to be a very traumatic event that triggers this. But anyway, that's all we've got for these slides. I'll see you in the next chapter.